early in life, which cannot be attributed actually to any structural or visual pathway. Most commonly it is unilateral, though it can be bilateral as well, and prevalence is estimated around 1.5 to 2% in various studies, so it's not a very correct number. So traditional amblyopia therapies aim at correcting the refractive error alone, which can improve visual acuity in both refractive as well as strabismic amblyopia. The traditional amblyopia therapies include optical treatment and penalization. Occlusion and penalization of the sound eye has been the gold standard of unilateral amblyopia for a very long time. However, young children with developmental delays, or children with severe amblyopia may not tolerate. If we come to pharmacological manipulation, drugs like atropine have been used. Low dose atropine of 0.01% has emerged as an effective approach, as highlighted by the atropine in the treatment of myopia studies, ATOM-1 and ATOM-2. Now we come to the emerging amblyopia therapies, which have shown significant progress in the recent years. We start from perceptual learning, video game play, dichoptic video game therapy, oculopad or oculotab, virtual reality, and interactive binocular treatment. Starting from perceptual learning, it's based on the principle that performance of sensory tasks can be improved with consecutive practice. It also involves practicing visually challenging tasks to promote long-lasting vision improvements. The perceptual learning training can be monocular or binocular and requires a rigorous supervised visual experience along with a specific feedback. It can present as an opportunity to treat adults with amblyopia who are thought to be treatment resistant. Coming to video game play, they have an added advantage over the perceptual learning since they present a variety of visual demands and different experiences. Playing action video games has also been associated with release of dopamine, which we do come across a lot of studies that even chocolate increases dopamine. Playing action video games also induces dopamine, which may promote neuroplasticity and therefore promote recovery. Then we come to another modality, that is dichoptic video game therapy, in which a fixing eye and an amblyopic eye view is given different stimuli by presenting essential game elements with high contrast to the amblyopic eye and low to the fellow eye. Thus, binocular viewing is a requirement in these tasks. Another, that is oculopad or oculotab, which is a device that processes pictures selectively in the disease eye under open binocular. The only requirement is it requires polarized glasses and a new widescreen technology. The widescreen technology involves stripping polarizing layer of the liquid crystal panel, and it is joined to a strip film. Along with that, there is another, that is interactive binocular treatment, which was developed to treat amblyopia using dichoptic stimuli via virtual reality game. The special software stimulates the amblyopic eye without compromising the fellow eye. The initial pilot studies have promised improvement in the visual acuity, and adult patients also with amblyopia. Use of shutter glasses has also been paired with this technology. Then coming to a very hot topic, which is use of virtual reality in different parts of ophthalmology. Unlike two-dimensional binocular therapy, VR presents a 3D environment in which the child or even a young adult is more visually immersed. This therapeutic approach allows to leverage the sensory motor adaptive capabilities involving the nervous system. While some of these studies do offer promising preliminary results, there is no consistent evidence that amblyopia treatment with any or therapies compared to conventional therapies does help. The fight is still on, and I think with time we will continue to evolve with newer modalities. So concluding it, first and foremost still remains the same. We should give suitable refractive corrections, followed by patching for 2 to 6 hours in a day, or pharmacological penalization. This can be increased to the length of the adjustment period to maximum per day, and along with educational programs, direct communication with children, their parents, and making sure that the follow-up visits over the years is strictly followed. Thank you.
Thank you, Dr.
Thank you, sir.
We will discuss at the end because we have a lot of papers. Let's finish with those first.